Hello, everyone. It's 6 p.m. here in Manila, in Southeast Asia. Good evening. Of course, good morning to you, Riza, in the US. And good afternoon to or good morning to our speaker today, who's joining us from, I believe, in Europe. So let's wait for maybe another minute or so as more of our co-learners are just entering our Zoom platform. Welcome to session 3, session 3 of the Southeast Asia Climate and Health Responder course. And this session will be focusing on climate change and infectious diseases. Again, I'm Dr. Renzo Ginto, the Director of the Planetary and Global Health Program of the St. Luke's Medical Center College of Medicine in the Philippines. And I'm very, very happy and excited that we are already on our third day in this 8-day, 8-session series dedicated to climate change and health. Of course, just a reminder that this course is brought to you by not only the St. Luke's Medical Center, but also the Global Consortium on Climate and Health Education based at Columbia University's Mailman School of Public Health and Healthcare Without Harm, Southeast Asia. So good evening to our co-learners who have just entered. And in a couple more minutes, hopefully more will be joining us. But since we have lots to cover in this session, maybe we should begin now. And before that, just a kind reminder to please keep your microphones on mute. Later on, we can unmute you during the Q&A. If you want to verbally ask your question, you can also use the chat box for your questions, your comments, reflections. In the previous 2 sessions, we were really glad that our co-learners have been maximizing the chat box, not only to ask their questions, but to also share materials, references, experiences. So I hope that we will keep the level of energy in this session. So today we are very privileged to be joined in by a dear friend from the Chuchi Darlin Hospital in Taiwan, which is just above the Philippines, an hour away from Manila. But right now, as I've mentioned, our beloved speaker is joining us from Europe. Maybe later you can tell us why you're there. The Vice Superintendent of the Darlin Chuchi Hospital, which is part of the Chuchi Medical Foundation in Taiwan. Please welcome to give us this session on climate change and infectious diseases, Dr. Mingnan Lin. Dr. Lin, thank you for joining us.
Yeah, hi, Renzo. It's really my honor to share the climate change and infectious disease with you. I'm now currently in Hamburg. I'm joining a governance board meeting of the HPH Health Promoting Hospital International Network. I am also chair the HPH and Environment Task Force, which means that most of my work is for reduce the climate impact from the healthcare sector. So I'm also proposing how to reduce the climate impacts in the HPH society. So thank you again for the invitation, that I have the chance to share our experiences. Thank you.
Amazing. Thank you, Dr. Lin. So in the first 30 minutes, we will be showing the recording of Dr. Lin's lecture. And then later on, we will open the floor for questions, the question and answer section. So can we just ask our colleagues to please show the recording of Dr. Lin's lecture. Thank you very much.
Hi, everyone. It was really my honor to be here, share with you the infectious disease and climate change from personal health to planetary health. As clinical physicians, our primary focus is on the physical health of our patients. However, we understand that in this era of climate change, environmental issues are one of the main threats to human health. So, in addition to caring for the health of our patient, we also need to consider their health in the context of climate change, which leads to many infectious diseases. Shifting from focusing solely on the health of our patients to considering the health of the environment is something we, as clinical healthcare providers, must strive to. This is the outline of my lecture today. I will briefly introduce the health issues caused by climate factor. Following that, I will discuss climate change and related infectious diseases. Finally, I will touch upon what we as healthcare workers can do. This exposure pathway is described in the White House report on climate change and health in 2016. As you can see here, there are environmental and institutional context, social and behavioral context. Climate driver will influence both context and through the links routes of pathway, which people are exposed to climate change impacts, which will affect human health, and there will be health outcome. Climate change will directly or indirectly harm to health of people. The direct harm such as
Sorry for that. I don't know what's happening.
Yeah, oh, it's okay that I pray from my side.
You'll just play from your computer, Dr. Lin?
Yeah. Can I make it?
Yeah.
I can pray from my side.
Alay, what happened? It was running smoothly until that slide.
Yeah,
Okay.
the PowerPoint asked for the camera and then it showed my camera. I don't know what happened. Yeah.
Okay.
Okay. I pray from my side. Okay.
Okay. Thank you, Dr. Lin. Apologies for
Okay.
that.
Okay, I pray from my side.
Yep. Alay, can you please unshare your screen and then Dr. Lin will do his. Thanks. I think there was something about the PowerPoint, but maybe it will work from Dr. Lin's computer.
Okay, I share my screen.
Erlene, everything okay? Oh, we can't hear the talk. We can't hear anything. We can only see the folder, your folder.
Okay. You see the, okay. Can you see that?
Yes, we can see it now. Yeah,
Can you
but
hear
we're
the
already.
sound?
Nope. Or can you
No?
play it again?
Yeah, I played it. I already played the sounds.
Yeah, we can see your face there. I think this is this specific slide where, as mentioned by Ale, it's requesting your camera to be on. Okay, now we can't hear anything. We can only see your slide. It says mosquitoes, sticks, sandflies.
Vector-borne diseases is in the slide. As you can see here, vector-borne disease.
Now we can hear something, Dr.
Okay.
Lin.
Sorry. Can you hear the sound? Infectious diseases.
We can hear it. I think there are some slides with no sound, but this one has.
Okay. So I'll play it again.
Hmm.
The key facts of vector-borne diseases is in the slide. As you can see here, vector-borne diseases account for more than 17% of all infectious diseases, causing more than 700,000 deaths annually. Malaria, which is a parasite infection transmitted by mosquitoes, and which causes estimated 290 million cases globally, and resulting in more than 400,000 deaths every year. Most deaths occur in children under the age of 5 years old. Dengue is the most prevalent viral infection transmitted by mosquitoes, and there are more than 3.9 billion people in over 129 countries at risk of contracting dengue. So there estimated 96 million symptomatic cases and 40,000 deaths. The other diseases we talked about before. So these are all vector-borne diseases. And this is the behavior and life cycle of mosquitoes. Brood-fed female will lay in eggs in the water, then become larva. The larva become pupa and leave the water, become a mosquito again when all the situations are okay. As you can see in the slide, temperature will influence the oviposition rate of the female mosquito. If the temperature is lower than 10 degrees Celsius, then the oviposition rate of the female mosquito will be much decreased. And then this is the egg hatching rate. The same. Temperature is also playing an important role here. If the temperature is lower, then the hatching rate will be decreased. And this is the emergence rate. What is the emergence rate? That means that the mosquito transits from water to air. It is also affected by the temperature, as you can see here. If the temperature is lower, then the emergence rate of the pupa will be also decreased. So, as you can see, 10 degrees Celsius is an important line for the life cycle of mosquitoes. If the temperature rises, then the situation for mosquito, for laying eggs, for hatching the eggs, and for emergence, that will be increased. So WHO reports in 2009, it said that from 1955 to 2007,
dengue fever instance increased 34, which with increasing geographic expansion to new countries. This is the estimate in 2019. The situation became worse. It's still the most prevalent area is tropical and subtropical country, but it expanded to higher altitude countries. In Taiwan, we have dengue domestic cases in below Jiayi, south of Jiayi, but now we have domestic cases in Taipei. So as you can see, the dengue fever, because of the global warming, the situation will become worse. This is an example in Taiwan. In the year 2015, there was an outbreak which caused around 40,000 new cases of dengue fever, and about 200 people passed away due to dengue, hemorrhagic dengue fever or dengue shock syndrome. As you can see in the slide, during the summer, in ER of the hospitals in Tainan City, almost the ER will have mosquito tents, and the nurses wanted to strike because of the heavy care burden. This is the key facts of waterborne diseases. Diarrheal diseases, approximately 1 million deaths worldwide, which is one of the leading causes of illness and death in children under 5. And then among the diarrheal diseases, cholera estimate 1.3 to 4 million cases, and they will cause 21 to 143,000 deaths annually. Typhoid and paratyphoid fever caused by bacteria that can contaminate water supply, estimate around 11 to 20 million cases per year, which will cause 128,000 to 161,000 deaths annually. Hepatitis A also transmitted through contaminated water, about 1.4 million cases each year. Schistosomiasis is a parasite disease spread through contaminated fresh water. There are about 220 million people required preventive treatment for this disease. These are all WHO key facts. The major pathways that climate change influence waterborne disease is through at least 5 aspects. First is the rising temperatures due to climate change that can increase the growth rate of waterborne pathogens, such as bacteria, viruses, and parasites. These can increase the likelihood of diseases such as cholera, typhoid. And changes in rainfall patterns include both heavy rainfall and drought can affect water quality and availability. Heavy rainfall can lead to runoff that contaminate water sources, while drought can concentrate pollutants in limited water supplies. Sea level rise can increase the salinity of coastal groundwater, threaten freshwater supplies, and potentially leading to increase in salinity tolerant pathogen. Climate change can also the habitat of disease-carrying microorganisms, leading to shifts in disease ranges and instances. For example, schistosomiasis is influenced by the range of snail hosts, which can be affected by changes in water temperature and quality. And the water scarcity will drive people to consume unsafe water, and that will lead into a rise in waterborne diseases. as the slide, the links, it depicted the links between climate change, water quantity and quality, and human exposure to water-related disease. As you can see here in this slide, infrastructure failure and agriculture activity as major source of water contamination in the US, both of which are exacerbated by climate change. Older cities with deteriorating water system can discharge raw sewage into water bodies during heavy rainfall or extreme weather event. As climate change is predicted to increase the frequency and intensity of the weather events, the risk of such contamination is expected to rise. Additionally, agricultural practices like using livestock manure and inorganic fertilizer can introduce harmful substance into water system, promoting hazardous algae growth. As climate change is expected to bring more heavy precipitation, the risk of runoff carrying these contaminants into water bodies will likely increase. Hence, climate change can significantly amplify both these water contamination issues. Let's talk about VBO. VBO is also a water-related waterborne infection. Water temperature, as you can see in the slide, is a major contributor to the growth of VBO. And in turn, it will increase the human exposure risk. The minimum water temperature threshold for the growth of most VBOs that cause illness in humans is 15 degrees Celsius. As the temperature increases, the growth rate will also increase. So the risk of human exposed to VBO will also increases. So this is a climate change and the VBO infection. These are key facts of foodborne diseases. Nearly 1 in 10 people fall ill from eating contaminated food annually, which will result in around 420,000 deaths each year. This is from WHO. Salmonellosis, this is a bacterial infection, estimated like 93.8 million illness, which will cause about 155,000 deaths. Norovirus, which is a viral disease, you can see here so many cases of foodborne illness each year, and especially in low-income country, they're estimated 200,000 deaths. Campylobacteriosis, this is a bacterial infection, also 93 million cases and 21,000 deaths annually worldwide. E. coli infection, there are various types of E. coli infection. Collectively, there will be like 120 million cases of diarrhea due to enterotoxigenic E. coli, which will cause 30,000 deaths in children under 5, especially in developing country. And because the foodborne disease shares some of the pathway with the waterborne diseases, so I won't talk about the pathway that foodborne diseases will increase the risk of human illness. But I would like to talk about another one indirect effects of the infectious diseases related to climate change, which is a zoonotic disease. I would like to share with you, actually, the 3-year COVID-19 pandemic, which is a zoonotic disease, is also related to climate change. Since the year 1976, the new emergent and re-emergent infectious diseases, and they're about like more than 75% of the new emergent and re-emergent infectious diseases are zoonotic disease. As you can see in this slide, Ebola in 1976, HIV in 1981, avian flu in 1997, SARS-CoV-1 in 2002, swine flu 2009, MERS 2014, and H7N9 flu or H5N6 flu, and especially 2019, the SARS-CoV-2. And also in the year 2012, the monkeypox is also a zoonotic disease that the virus share. The virus is on the host of the animals, but jump into human beings and cause a lot of health problem of the human beings. Yeah, this slide shows the geographic distribution of the zoonotic disease in Asia, in Africa, in Europe, in the America. These are all zoonotic diseases. This is major pandemic outbreak in recorded history. In this slide, you can see the environmental issues leads to the zoonotic disease pandemic, the climate change, which will result in rise in temperature, transmission of vector and pathogen to human, which will result in propagation of disease and pathogen, and over-reliance on animal meat. The unplanned urbanization because of high population density in the big cities with unhygienic conditions and formation of slums results in easy transmission and spread of pathogen. The biodiversity loss, huge decrease in biodiversity that is due to anthropogenic activities, has increased livestock cultivation and even resulted in culture of wild animals through backyard farming, resulting in transfer of new strain of pathogen. Bushmeat trading, global trading of wild animal increases contact between human and animal, like increase the risk of new zoonosis diseases, emergence among human population. Intensive livestock farming, because the livestock cultivation increased, but with poor sanitation, unsafe disposal of animal waste, which will result in breeding and transfer of pathogens to human. Farming of wild animals has further aggravated the problem, causing in transfer of novel pathogens. Deforestation and habitat fragmentation. Habitat loss and fragmentation is resulting in more man-animal conflicts. Movement of animals, that is reservoir of novel viruses of bacteria toward human dwelling and interaction of wildlife with livestock, resulting in transfer of novel microbial pathogens. Yep, all these are the issues that we need to deal with, because this will lead to zoonotic disease pandemic. We talked about COVID-19 because this is the interaction between non-communicable diseases and infectious disease. Because of the habit of eating, we have diabetes, hypertension, cardiovascular diseases. If all these patients contract with COVID-19, the critical and mortal cases will increase, like from 3/4 to 5/4. So these are the interaction between infectious diseases and non-communicable diseases. I read a book in 2020 when the pandemic emerged. This is by David Quammen, Spillover, Animal Infection and the Next Human Pandemic. I was quite astonished that the scenery depicted in this book is just like what happened in 2020. The author said that in the year 2016, the next big human pandemic, the next disease cataclysm, perhaps the scale of AIDS or the 1918 influenza, is likely to be caused by a new virus coming to human from wildlife. And the comment said that, for this book said that, when we encroach on wildlife, cornering them, exterminating them, or even consuming them, we contract their diseases. Humans step into the territory of pathogens, creating excellent conditions for themselves to become new hosts, also provides mysterious pathogens a new environment for transmission, thus inviting the next big one for ourselves. Coronavirus, there are now 7 coronavirus isolated from human. The first 4 will cause like 30% of common colds. And COVID, SARS, MERS, and SARS-CoV-2, they are all quite lethal. SARS has 10% case fatality rate, MERS like 30% case fatality rate. When SARS-CoV-2 in the end of 2019, the original strain will cause like 5% of case fatality rate, but now it decreased 100-fold. But still, because we don't have any immunity towards SARS-CoV-2, so it cost officially in the record more than 7 million people pass away due to the COVID-19. And why bats matter? Bats is very important for different agriculture, biodiversity, eat harmful insects. But the habitat of bats was destructed. We know that there are more than 1,400 species of bats, and they carry more than 200 different coronaviruses. And loss of natural habitats is the most widespread peril for bats worldwide. And human activities are rapidly depleting forests, threatening the habitats of bats, especially those in biodiversity-rich tropical rainforest. So countless number of bats being driven out. They carry different species, different kind of coronavirus. So the zoonotic diseases, the next pandemic will also come very soon. We don't know, but actually with quite a big chance that the next pandemic will come. This is also a zoonotic disease that caused by climate change indirectly. In BMJ, the recommendation for healthcare professionals to reduce the infectious diseases due to climate change. Firstly, we have to think about how to decarbonize the healthcare system, increase the funding for climate health research and practices, encourage a transparent, transdisciplinary approach, and support interdisciplinary activities. And we need to incorporate environmental information into public health practices and assessment. And for the healthcare sector, we need to invest in decision support, modeling tools, and communication, and build human capacity in data management, integrated surveillance, and leadership. So I'll briefly talk about the surveillance system and the climate-driven predictive model. So these are all proposed by WHO or some of the scholars like WHO since the year 2010 have already have integrated disease surveillance and response system. And then some climate-based disease forecasting models, remote sensing and geographic information system, GIS, proposed in 2002, and their syndromatic surveillance, bioinformatics and genomic surveillance, community-based surveillance, and public and climate data integration that we as healthcare professional, we need to, facing the climate change era, the infectious diseases emerges, the pandemic is expected. So through the pandemic for the 3 years, we need to build up the resilience of our healthcare system, building up the surveillance and the climate-driven predictive model. I'm Dr. Minanin. Thanks for your listening. The infectious disease due to the climate change is now also a very important issue for healthcare sector. Hopefully that everyone, as many as possible, that the physicians can know more and think about more when treating the patients. And then we have to think about how to improve the environment. Thank you.
Okay, well, thank you very much, Dr. Lin, and for your presentation. It's great that we were able to solve that initial tech hiccup that we encountered. And thanks for all the information, the advice, the recommendations that you have given. I'm seeing some colleagues already sharing their thoughts, particularly about the plant-based diet. So I invite everybody to keep on raising your questions and comments in the chat box. I also noted that Dr. Lin has already begun answering some of the questions, but some of them I might still ask nonetheless, so that it will be in the recording and so that others who may not be reading the chat box can also provide or can also hear your answer to the questions. So there's one question about, of course, you touched already, you already showed a slide where you showcase the different emerging infectious diseases. There's a question here, is Ebola related to climate change, especially the outbreak that we had a few years back in Africa? Maybe you can also comment on COVID-19. So how are these recently emerging or re-emerging infectious diseases connected to climate change? Dr. Lin?
Yeah, thank you. Yeah, there's a couple of emerging and new emerging infectious diseases, such as Nipah virus, hantavirus, and Ebola is the first one which has been identified, mostly from bats. So bats carry a lot of different viruses that will be new to human beings. So the first thing is that we reduce the risk of contacting all the wild animal. So I propose just in the chat, I said that if we can reduce the chance to contact with them. Yeah, somebody asked that avian flu is from the bird. How can we control the bird? But actually, avian flu, there's some chicken farm. We got the avian flu maybe because the bird context the chickens in the chicken farm, so they mix together, and then they will transmit to the farmer, and also maybe to the market, and then transmit it to the general population. So yeah, it is not easy, but I think that become a whole vegetarian is not easy. But if we can cut down the consumption of meat, especially the wild animal, that will reduce the risks. We have a good vaccination for different flu, such as we have swine flu in 2009, and it can control not easily, but quite fast, because we have this kind of tools. But for some viruses that's very new, such as coronavirus, the COVID-19 is very new. So I think maybe next pandemic also maybe from coronavirus, but we can maybe in 1 or 2 years compare with this time 3 years, we can have the chance to better control because we have the experiences. But we don't know there are other viruses, especially the zoonotic diseases. These are some new viruses. We don't have the experience. We don't have the immunity. So yeah. My suggestion is at least we reduce the chance to contact with the wild animal. That will reduce the risk to contract the zoonotic disease.
Right. Well, thank you, Dr. Lin. And well, that's an interesting thing. We even sometimes, even if we have already an experience of a crisis such as COVID-19, we tend to forget the lessons and not to apply them and implement them. And then we just return to that vicious cycle, and then we'll have another pandemic, and then we will have to try to sort things out. So yes, I definitely agree with you. We already have the experience, but we need to learn the lessons. And we need to make sure that they are institutionalized. But for example, you mentioned that, yes, for viruses that we are already familiar with, we know we have the experience, we have the vaccines, we have the knowledge. But for new ones, right? Viruses, pathogens that we are not very much familiar with, what I'm hearing from you is, I think the principle is we reduce our interaction with wildlife. So maybe you can just share a bit about ways to make sure that happens. What sort of policies and practices do we need to implement to reduce our interaction with wildlife? And maybe you can cite some experiences from Taiwan.
Yeah, it is a global problem, right? Such as we call deforestation. Deforestation, that we create the chance to contact with wild animals. Why we need to do that deforestation? Because we need to have more crops for cattle, for the livestock. So it will in turns increase the global warming because of the deforestation, and then raising cows, and then also other livestock will also have some methane, and this is a vicious cycle. So my proposal is that we cut down the meat consumption. So maybe we will at least slow down the vicious cycle. Yeah, so maybe it is a way. So I'm now the president of Taiwan Vegetarian Society, Taiwan Vegetarian Nutrition Society. That my title is from personal health to planetary health, right? So for personal health, I think that most of the physicians know that if we cut down the meat consumption, it will be beneficial for metabolic diseases, cardiometabolic diseases such as diabetes, coronary heart diseases. And also, this is beneficial for human health, and also because we can reduce the global warming, reduce the methane, preserve the rainforest. So one action for two solutions. So we can, what we can do is that cut down a little bit meat consumption.
Right. And what I'm hearing from you are two things. Number one, this really requires a cross-sectoral collaboration because you need to address deforestation, you need to address meat consumption, you need to address the healthcare system. Everything is interconnected, right? And if we are going to stop infectious diseases from spreading, we need to address all of these sectors. It cannot just be a purely clinical approach. The second thing that I'm hearing from you is that if we do that, we will be enjoying a lot of what we call co-benefits. We will be safe from pandemics. We will have a healthier climate. We will also have less chronic non-communicable diseases due to increased meat consumption. And actually, the session on Thursday will focus on non-communicable disease. So to all our co-learners, please make sure that you join us on Thursday, because you will also hear about these other co-benefits to chronic non-communicable disease prevention. So it's not only the microbes, the bacteria, the virus, we're also going to address NCDs. Going back to meat consumption, a while ago we're talking about wildlife, but we also need to address our interaction with domestic animals, domesticated animals that we use in for our food consumption, that we produce in large-scale farms. Can you cite some concrete measures, examples, policies, practices that you are promoting, that you're actively doing in Taiwan, that you are advocating for in the Taiwanese Vegetarian Society? So if, to our co-learners, if your country does not have yet a vegetarian society, maybe you can follow the example of Dr. Lin. So maybe you can comment on practical solutions to reducing meat consumption.
Okay. The first thing is that I think that we need to have more nutritional curriculum for medical professionals, because there were ample evidences that we know that plant-based protein is better for animal-based protein. But because medical professionals like nurses, doctors, they are quite trustworthy professions. So there's some ranking that nurses number 2 trustworthy professions, and doctor no better than nurse. We are the 4th trustworthy professions. So if the medical professions, they know that it will be better to cut down the meat consumption, then the awareness of the medical professionals can also convey this message to our patients. So this is, we know that global warming will, increase the vector-borne disease, especially mosquito-borne diseases. So that will increase the burden of ourselves. So if we are doing just the downstream work to treat the disease, then we have so many patients to treat. But it is pity that we don't have this kind of curriculum, especially for climate change and health, or about nutrition in the medical curriculum. So I think that what we can do, what I'm proposed, that besides do research on plant-based diet, better for human health, but I think that we need to propose to increase the climate change and health curriculum, and also the nutrition curriculum to the medical professional, healthcare professional, especially doctors. So it is a way that I'm now working on. I hope for that the collective power of all of us, we can encourage or persuade the government, persuade the medical professors to adopt this curriculum, and then for the young generation, they can have more and more awareness of this concept. That we can, with the same mindset, that we can have a better health condition of the patient, of the people, and also a better environment.
Thank you, Dr. Lin. And that's why we have this course, right? We're trying to really educate and even re-educate the health professionals to become more climate resilient, climate smart, climate responsive. And for example, in terms of preventing and controlling the usual infectious diseases. A while ago, we were talking about the emerging infectious diseases, but we need to remember this is a message to our co-learners, even the more familiar diseases like dengue and waterborne diseases, foodborne diseases, all of them will be impacted by the climate. So we need to start putting climate in the equation when we address both the new diseases, but also the old diseases. Yeah. And I think part of it is improving our disease surveillance systems. There's a question here, Dr. Lin, can you expound more on the applications of GIS, Geographic Information Systems, and remote sensing? You know, is it more geared towards evaluation of changes in land use, reduction of habitats of disease-carrying organisms, or prediction of spread of these organisms? So it's related to your surveillance slide.
Now, there are a couple of surveillance systems, such as we call the now, because the heat, right? The heat, we can have some satellite and then monitor the heat. And then because the weather, the temperature is related to different kind of infectious diseases, such as the dengue fever. And then the other things that we need to monitor, like the larvae of mosquitoes, and then put all this together, we can predict, well, there will be an outbreak of dengue. So this kind of surveillance system, we can have like this early warning. And now in Taiwan, there is because the health administration, health promoting administration work with the like for weather forecasting administration, that they can like have some, if the heat, the temperature is too high, they can have some early warning for the patients, because they are very vulnerable. They have heart disease if the weather is too hot. When they travel or when they come to the hospital, they will maybe have some problem because of the heat. So this early warning system is, the infections disease or all climate related situation can be built up for warning the vulnerable population. So we are now, I think that climate sensitive diseases, not only the infectious diseases, but also some vulnerable population with chronic diseases, heart diseases. If we can have this kind of early warning and climate-driven, predictive system, then maybe it will be safer for our patient.
Thank you so much, Dr. Lin. I know that you have a time limit because you also have a meeting there in Germany. I'm not sure if you can accommodate maybe one or two more questions. Let me know.
Okay, it's okay now. It's okay now.
Okay, good. But what I'm seeing is actually a lot of supportive comments to what you're saying. Many are saying yes to plant-based diet. I think you're now starting a food revolution here, Dr. Lin. People are now mentioning we need to involve other sectors to reduce our interaction with wildlife. Habitat preservation is a must. We also need to look at antimicrobial resistance, right? So that's another emerging infectious disease concern. Some are saying that will be the reason for the next pandemic. And it's going to be much harder to address. So while we are still not yet in that point of no return, we need to really act fast. And transitioning our diets is an important answer to that problem. Dr. Lin.
Yeah, I would like to share an experience of mine, because I'm now working on the Taiwan Association of Family Medicine. So it's also a medical educator. So I propose to our association that I write an article and we put it on the textbook for the resident. Because in our Taiwan Association of Family Medicine, there are 3 textbooks: preventive medicine, family medicine, and community medicine. All the young residents, they need to read out the textbook and join the board exam. So I read an article about climate change and health. They need to read that. So I'm thinking that if we can, the medical professionals, professors, teachers in different specialties. In 2 years ago, when I attended COP26, I met a pediatrician from UK. They put climate change issue into their CME, continuous medical education. That is mandatory. So if for the medical professional, that we can have this kind of awareness, that I think that will be, because we are a credible voice for the people and then for the patients. So it is a way that we can do that.
Thank you very much, Dr. Lin. Well, I think actually that is a very great way to end this segment, that call to action. And I hope that more of our fellow health professionals in this course will really step up and embrace this new mission, right? Not just to heal our patients, but also to heal the planet, to protect our communities from infectious diseases. And what really we're realizing is that it's not anymore just about having the right antibiotics and vaccines. We need to address the upstream drivers of infectious disease, emergence and reemergence. And it can start with the food that we eat every day. So thank you again, Dr. Lin, for your time. It's really always a pleasure collaborating with you, and hopefully in the coming sessions and courses, we can again engage you.
Thank you.
And inspire more health professionals in Asia and beyond. Thank you again, Dr. Lin.
Thank you very much. Thank you.
Okay. So we still have around 20 minutes remaining. And as you recall, the second part of our program is dedicated to more practical skills and cases. And what we're going to do now is to show to you 2 recordings of patient-doctor interactions where the patient is experiencing, having a chief complaint related to an infectious disease that is sensitive to climate change, or that is highly influenced by climate change. And we're showing these clips to you so that, one, you will be better equipped in your history taking, in your diagnosis and treatment, but also in your public health response. When you are given the chance to encounter a patient or a community that is affected by a climate-sensitive infectious disease. So that is what we are going to have today. We'll show to you 2 short clips, and then we will have one of my colleagues from the Planetary and Global Health Program of the St. Luke's Medical Center College of Medicine to give a summary or a synthesis of what you are about to hear. So can we now have the first doctor-patient conversation or interview? And maybe in the chat box you can put or write in the comments about the case. What do you think is the patient experiencing? What climate-sensitive infectious disease is affecting the patient that is being interviewed? So now let's listen.
I would like to welcome you to the first clinical case of the 3rd session of the Southeast Asia Climate and Health Responders course. Those of us who will be presenting this session to you include myself, Dr. Raisa Udin, as well as Dr. Alyssa Lee Ismail and Dr. Timothy Karandang. This case is about Kru Charanyatru. She's a 32-year-old female, and her height is 162.5 centimeters. Her weight is 75 kilograms, and she has a BMI or body mass index of 28.3. Ms. Crew is a 32-year-old woman who has 28 years of experience working as a street food vendor in Chatuchak. She also makes supplemental income through waitressing in small restaurants. She lives nearby and is coming into the Bangkok metropolitan area clinic today because she has been experiencing some loss of appetite, undocumented fever, frequent headaches, and abdominal pain, which has been worsening for 5 days now. It has been interfering with her ability to work productively on her 2 jobs in the Chatuchak area. Her husband has noticed that she has appeared sicker than usual. Presenting this case will be Dr. Ismail, who will play the role of the patient, and myself, I will be playing the role of the doctor. We will now begin the case. Hello, Ms. Crew. I am Dr. Udin, and I'll be seeing you today. Can you please tell me what brings you into the clinic today?
Good morning, doctor. My husband insisted that I come in today because I have been having frequent stomach pain and losing appetite. I keep on getting nauseous, and I also have an on and off fever. I think maybe it's related to the recurring vomiting I'm having as well.
I see. I'm so sorry to hear you've been experiencing these symptoms. It sounds pretty troublesome. Can you tell me a little bit more about what's been going on?
Well, I guess I've been having this feeling for the past month. It can also be because of the weather. Since I've been working, even if there's a storm, and I'm not as hungry anymore. And even though I eat less and continue to work 2 jobs as a street vendor and waitressing, I get this abdominal pain that comes and goes often. And I used to have a big appetite, but recently I'm not keen on eating a lot, partly because my stomach ache is becoming more frequent. The last 2 weeks, I've also been coughing and having intense headache.
I see. So it sounds like to me you had some symptoms originally, and now more recently, some of these symptoms are presenting newly and some of them are getting worse. Is that right?
Yes, doctor.
When did you first notice that something was wrong?
I think it's been 3 weeks. I think I had a fever then and now. And then think about it, I might have started getting nauseous, but it resolved eventually. So I didn't think much about it.
Okay. But you're coming in today because it's been getting worse, huh?
Yes.
Has this ever happened to you before?
I had the same feeling before when I had food contamination.
Okay, I understand. You had mentioned that you've been having some abdominal pain. Can you show me where it's been hurting?
It's here, doctor.
Okay,
Right on top of my belly, and then it radiates to the left upper stomach.
see, okay. Does it seem to hurt all the time, or does the pain come and go?
The belly pain comes and goes. It's not constant, but it occurs pretty often.
So I'm gonna summarize the symptoms that you've listed out to me. If that's okay, please let me know if I miss anything that you might have already said.
Okay, doctor.
To me, it sounds like about a month ago, after the storms and the flooding happened, you had some fever, some nausea and vomiting, along with some other symptoms. It initially improved a little bit, but now you're coming in because of this recurrent abdominal pain that's bothering you, as well as continued loss of appetite.
Yes, doctor.
Okay. And I should also mention you have been having a cough as well and
Yeah.
headache. Have you done anything to make it better?
To make it better, the nausea can be better if I drink plenty of water on some days. I've also tried paracetamol for the abdominal pain, but I ended up vomiting it. For worse, it's worse when I forget to drink water during the day.
Okay, I understand. Have you had any other symptoms that you've noticed? For example, have you had any changes in your urination or been feeling more thirsty than usual?
I've been urinating regularly.
And have you been having regular stools?
Yes.
Okay, good. What medications, if any, have you taken at home?
Just paracetamol for the pain.
Have any other members of your family or any of your friends or other contacts, if they've been sick?
Yes. My friend, the fellow street vendor, recently got admitted to the hospital because I think he stopped urinating. His eyes became yellow.
I'm so sorry to hear that. I hope he gets better soon. Do you think he had any symptoms that were similar to what you've been having?
The fever, yes.
I understand. Okay. If it's okay with you, Mrs. Crew, I would like to go ahead and ask you some additional related questions at this time.
Go ahead, doctor.
Do you suffer from any chronic medical conditions?
No,
Have you had any surgeries in the past?
none.
Who do you live with?
I live with my husband only.
And what is your current living situation?
We live in a small apartment near Chatuchak.
Okay. Do you have running water in the home?
Yes, we have running water.
Okay. Do you smoke or drink alcohol at all?
Occasionally, I drink alcohol during the holidays, but it's not a daily or even weekly occasion. And I don't smoke.
I'm glad to hear that. What about any use of cannabis or any illicit drugs?
Not for me, though.
Good to hear. Okay, so now I want to ask about some environmental exposures. You had mentioned that there was a storm recently, and with the changes in the weather, you noticed your symptoms around the same time. Have you been exposed to any floodwaters or stagnant rainwater anywhere?
I recall there was a typhoon a month ago, and I had to quickly come home. But unfortunately, the rain caught up with me, and I had to push my store cart through the flood.
Okay. That must have been pretty traumatizing.
Yes, it was. Yeah.
Okay. What about exposure to any mosquitoes?
We can't get rid of the mosquitoes at home because there's a leaking sink in the kitchen.
Okay. And tell me about the work that you do and what kind of things you might be exposed to at work.
In the day, I'm a waitress for a small restaurant, and I'm also a street vendor during the weekend. So I sell foods in the Chatuchak area.
Okay. All right. Well, thank you so much for sharing all of this information with me. I'm going to gather my thoughts on everything you've told me, and we are going to proceed to the physical examination. Is that okay?
Yes, doctor.
All right. Please follow me to the examination bed. Now we are going to talk about the physical examination of Mrs. Crew. As we go through the physical exam, please consider what the differential diagnosis might be and feel free to include your thoughts in the chat. When we examine Mrs. Crew, we see that she appears fatigued and slightly pale. She has a mild low-grade fever with a temperature of 38 degrees Celsius. And she has mildly jaundiced conjunctiva with dry and yellow tinged mucous membranes. Though her pulmonology exam is unremarkable, she does have an occasional non-productive cough during our visit. Her gastrointestinal exam reveals mild hepatomegaly and splenomegaly, as well as mild to moderate epigastric abdominal tenderness. And on her skin exam, we see that she is mildly jaundiced. The rest of Mrs. Crew's physical examination is unremarkable. Now, Mrs. Crew presented with the constellation of symptoms that is shown here in the image in the middle. She had a high fever, abdominal pain, headache, nausea, vomiting, and diarrhea during her initial illness, which she noticed a few weeks ago. This had seemed to get better, but then returned again, now with the addition of jaundice noted on physical exam. This type of non-specific illness that appears to be like a virus, such as influenza, can be from a wide range of infectious diagnoses. In endemic areas, you should consider diagnoses such as malaria, dengue, typhus, typhoid fever, hepatitis A, and hemorrhagic fevers, amongst other infections. In this case, the patient, Mrs. Crew, has a zoonotic infection that is caused by a bacteria called leptospiros. So this diagnosis is leptospirosis. Leptospirosis can present in a biphasic manner, with an acute stage initially consisting of the febrile stage, along with myalgias, headaches, gastrointestinal symptoms such as nausea, vomiting, and diarrhea, as well as a rash, amongst other symptoms. This initial stage may resolve, and some patients may not see a subsequent stage. However, in some cases, patients may present with an immune phase, during which they may have worse symptoms than before. The worst kind of While we are going through this section, please consider the differential diagnosis and please feel free to share your thoughts. Acute stage, which consists of a febrile illness along with myalgias, abdominal symptoms, headaches, etc. Later, if patients do develop an immune phase, they may have a more severe form of leptospirosis known as Weil's disease. This can present with hepatic symptoms such as jaundice and hepatic failure, as well as renal failure. This form of leptospirosis may be severe enough to warrant ICU hospitalization. Now, for the workup, we must consider the wide range of symptoms that leptospirosis can present with, and go ahead and obtain a complete blood count and metabolic panel, as well as a coagulation panel, inflammatory markers. Because of the hemorrhagic symptoms that leptospirosis can present with, a fecal occult blood test can also be helpful. To rule out infectious diagnoses, we could obtain stool ova and parasites, a hepatitis panel, dengue titers, and serologic tests. Urinalysis and a urine culture may help. And if the patient were to present with signs of aseptic meningitis, we could consider a lumbar puncture to obtain CSF samples. In this case, the most important or diagnostic test would be the serologic test. In cases of cardiac symptoms, we could consider an electrocardiogram. And for Mrs. Crew, we should consider getting a first-line whole abdominal ultrasound, as well as the chest x-ray given her cough. Further imaging may be warranted. In the management of leptospirosis, mild leptospirosis is often treated most commonly with oral doxycycline with outpatient monitoring. Moderate to severe leptospirosis can require hospitalization, as well as parenteral antibiotics such as IV penicillin or ampicillin or ceftriaxone. Electrolytes and fluid imbalances must be monitored, and We should also monitor for potential renal failure, pulmonary hemorrhage, and respiratory failure, as well as shock. That concludes our case, our first case. We will now conclude this session and move on to the next case. Thank you.
So it's already 7:25, and as you're aware, we had some technical glitches at the start. So I hope that you can still stay with us beyond 7:30. Let's have the second case, and then one of our colleagues will just give a quick synthesis about the two cases. Can we already play the next one?
Hello, everyone. I am Jerome Jarito from the St. Luke's College of Medicine.
We can't see anything, Ale.
And we will be presenting.
Yep.
The second case for the clinical skills session of the Southeast Asia Climate and Health Responder course. This case is about Vibol Chihon, a 40-year-old male with a height of 157 centimeters, 49 kilograms of weight, and BMI of 20. Vibol has had 18 years of rice farming experience in the Sabo district of Cambodia, with supplemental income through fishing. He lives beside the farm and is visiting the village health center today because of worsening abdominal cramping and enlargement over several months, both of which have been interfering with his work. He also feels less energy, and his wife has noticed that he is unusually pale. Presenting and simulating the case for today are myself, who will be simulating the patient, and the doctor, who will be simulated by Dr. J. Cortez. We will now be proceeding with the case simulation. Good morning, doctor. I'm Mr. Vibol, and I wanted to come in for a checkup.
Good morning, Mr. Vibol. I'm Dr. Jake, and I'll be your doctor for today. Yes, I can help you with that. Please take a seat. What brings you to the clinic today?
I find it unusual, doc, that I've been getting thinner and weaker recently, but then my belly's still getting bigger, and it's also starting to hurt, and I have diarrhea as well.
I'm so sorry to hear about these things, sir. But can you please tell me more?
So for the past 2 months, I haven't really been able to farm properly because I always feel weak all the time. And I'm also not as hungry, so I don't eat as much anymore. But I still continue to work on my farm anyway. But even though I'm still working and I don't eat as much, I still feel like I'm getting heavier and my belly still seems to be getting bigger and bigger. I also get this pain in my belly that's it's there almost all the time, but sometimes it disappears for a while, but then it just comes back again. I also hardly eat now, but I'm not sure if it's food that's causing my problems. I'm a farmer, so I eat a lot of rice, but I also fish to help supplement my income. So that means I also eat some of the fish that I catch. But even then, I don't really have an appetite for those anymore. And I also saw some blood in my stool the past 2 weeks. So I wanted to check up and see what was going on.
I see. Mr. Vibol, for me to help you better, is it okay if I ask additional specific questions?
Yes, go ahead, doctor.
Okay, when did you first notice something was off?
I think in the past few months, doc, my belly's been getting bigger. But even before it started getting bigger, I think it started to hurt. But at the time, I thought it wasn't anything special. I thought it would just disappear quickly.
I see. Has this ever happened before?
Maybe once or twice, but that was probably a long time ago, doc. I do remember that there are some farmers that from the nearby farms that also said that they've been experiencing the same problems.
Okay, can you please point to me where it hurts?
It hurts over here, doc, right above on the top of my belly.
Does it hurt all the time or just some of the time?
It hurts most of the time, Dom. Almost all the time it's hurting, but there are times where it disappears for a short while before it comes back.
Okay, I know you already described to me your abdominal pain, but can you please describe it to me further?
Well, Doc, I feel like lately I've also been more tired than usual. I've been really fatigued lately. And when I'm outside working on my farm or when I bend over and then stand up, I usually tend to get lightheaded and dizzy. I also find it weird that even though I'm used to physical labor as a farmer, and even though I'm not working as hard now as I am compared to before, I'm starting to get muscle cramps, which I don't usually experience.
Okay, for your abdominal pain as well as the additional symptoms that you have just described, have you done anything to make it better, or did you notice something that made them worse?
I noticed that if I drink a lot of water, usually my lightheadedness isn't as bad. And I tried to drink paracetamol for the belly pain, but it doesn't really help me that much. I also tried to eat a bit more to see if it could help with the pain and make it go away. But I also haven't had that much of an appetite lately, so I can't really eat as much.
I see. Have you taken any medications at home?
Just the paracetamol for the pain though.
Okay, how about any other members of the family, any friends, any co-farmers or close contacts who are experiencing the same symptom?
The other farmers also, Doc, in the nearby farms have said that they've also been getting sick.
Okay, so besides these conditions that you're consulting with me at the moment, do you have any other chronic medical conditions that I need to be aware of?
I've been diagnosed with high blood pressure and chronic bronchitis in the past, Doc.
Okay. Have you undergone praziquantel treatment in the past?
No, Doc, I don't think I have.
Okay. Any surgeries?
None, Doc, none, no surgeries.
Okay. Just to be thorough and so I just get to know you much better. May I please know who you live with at home?
I have a wife, Doc, and we have 3 children, and we also have 3 dogs that live outside our house.
Okay. Can you please describe to me your home, your living situation?
So I live in the farm, Doc, around 5 kilometers from here, so it's not very far. We pump our water from the lake, and we also have some electricity, but it's not very stable, so we don't really rely on it.
Okay. Do you smoke or drink alcohol?
No, Doc, I don't. Well, I sometimes drink maybe when there's a special occasion or during the holidays, but I don't really drink that much.
Okay. Again, sir, just to be thorough, any history of illicit drug use?
No, Doc, I don't use those.
I see. How about in your family? And I'm referring to your mother, your father, as well as your siblings or close relatives. Do you have any family history of diabetes, hypertension, asthma, tuberculosis, or cancer?
No, Doc, I don't think anyone in my family has these.
Okay. How about in your household? Any condition or any ongoing treatment?
Right now, Doc, no, I don't think anyone has anything going on right now.
Okay. How about your wife or your children? Have they undergone praziquantel treatment as well in the past?
I think my wife has undergone it twice in the past. No, I'm not so sure.
Okay. You mentioned that you do have pets at home. Can you please describe to me where they usually stay?
We usually keep them outside the house, Doc. They're not allowed inside the house.
Okay. And then you also mentioned that you are an experienced farmer, and you also do fishing as an additional source of income. Have you noticed any issues in the farm or in the river that you fish in?
In the river, Doc, no. But I've noticed that in the farm, there have been more snails recently, and it's also been a problem that the other farmers have mentioned that because usually we do see snails sometimes and they are pests on our farm. But recently they've been getting worse, and there have been more of them recently. We usually get our water from the Mekong River, and I think the snails started getting worse when they built that new dam near our farm in the river. And ever since then, I think I've noticed that's when the snails started getting more common.
I see. Were there any interventions done to control the number of snails in that farm?
Yes, Doc, we use molluscicide to try and control the snails.
Okay. Sir Bibol, can you please describe to me how you do your farming? Like, do you use footwear, any protective equipment?
Well, Doc, since it's hot, I don't usually wear a lot of protective equipment. I usually just wear a light shirt and some shorts, and I try not to wear any shoes because it gets hard to walk in the farm when we're irrigating since it's very muddy. And usually we're wearing footwear, it gets stuck in the mud. So I'm usually just barefoot in the farm.
I see. Thank you for sharing that. Do you have any other information that you would like to share with me?
Well, maybe Doc, that I also fish in the Mekong River because as I said, I also fish to make a bit more money because the farming isn't enough to cover our needs. So I fish to add a bit of income to our household.
Okay, I see. Thank you for sharing that. We will now be proceeding to the physical examination. Can I please invite you to the examination room?
All right, thank you, Doc.
Great, thank you. On the physical examination, the patient looked emaciated, fatigued, and pale. Additionally, the patient's abdomen was distended with shifting dullness, firm and irregular liver edge, and splenomegaly. The rest of the physical examination findings were unremarkable. In the primary care setting, common differential diagnoses for patients presenting with abdominal distension include the 6 F's, which refer to fluid, flatus, feces, fetus, fat, and fatal tumor. In this case, fluid or ascites is more likely due to the presence of shifting dullness on physical examination. Ascites is commonly due to either a hepatic or cardiac etiology, with the former being more likely for this case due to the presence of hepatosplenic abnormalities on physical examination. Depending on the availability of resources, several imaging modalities may be considered to confirm the clinical suspicion of ascites, with ultrasound being the recommended first line for hepatic etiology. Usual sonographic findings for this case may include a shrunken cirrhotic liver with splenomegaly and ascites due to portal hypertension. Alternatively, in the hospital setting, a diagnostic paracentesis may be conducted for patients presenting with clinically apparent ascites to analyze the fluid and determine the likely etiology. Based on the patient's clinical presentation, occupational exposure as a farmer, and epidemiologic prevalence of the infection, the primary clinical impression for this case is hepatobiliary schistosomiasis. The gold standard confirmatory test for such cases is fecal microscopy, usually using Cato-Cat's method, where the eggs of the parasite may be characterized according to its species-specific morphology. Of these, Schistosoma mekongii is widespread in Cambodia, and with predilection to the gastrointestinal and hepatobiliary tract. Supplementary laboratory tests may be requested to complete the patient's clinical evaluation. While praziquantel remains to be the drug of choice, hepatobiliary schistosomiasis and its complications are best managed by a multidisciplinary team alongside ongoing follow-up, screening, and environmental control. For a more detailed discussion of its clinical management, please scan the QR code flashed on screen. Mr. Bibol, it seems that you are experiencing liver complications of a parasitic infection known as schistosomiasis. You most likely contracted this infection in your fieldwork as a farmer. Rest assured, treatment with praziquantel is safe, effective, and available. Additionally, I will be referring you to my colleagues so we can help you get better together. Sounds good?
Yes, Doc, that's very great. Thank you so much for your help.
Okay, I'll see you soon. Thank you.
Thanks. Thank you very much, Jake and Jerome, for that patient-doctor interview. And I'm seeing that apart from our co-learners trying to identify the condition of the patient, they're also commenting about the sympathetic nature of the doctor and the quality of the patient-doctor conversation. And this is something that we also want to convey and share to our co-learners here, not just the technical content, but also the manner by which we should be delivering healthcare even in the era of climate change. So I know that we are already several minutes past the end of the course, but we now have Dr. Timothy Karandang to just give us a quick synthesis of what we just heard from the two clinical cases. Tim, the microphone is yours.
Thank you, Dr. Enzo. I'm here. I am Dr. Timothy Karandang. I am here to present about the synthesis of the two cases on schistosomiasis and leptospirosis. So let's discuss schistosomiasis. And first, let's discuss the effects of climate change on schistosomiasis incidence. So first, let's take a look at the endemicity of S. mekongii. It is mostly found in southern Laos and northern Cambodia in the named provinces. So along the Mekong River, there is a historical endemicity of schistosomiasis. We can further understand the effects of climate change on schistosomiasis by studying the life cycle. So schistosoma in general has two parts of its cycle, the sexual and asexual. The sexual being happening in the definitive hosts, in the mammalian hosts, and asexual in the intermediate hosts, which are the snails. And to be considered here further is the transmission through feces or urine, and we will take a look at that further as I present the public health pearls. So this is the intermediate host of S. mekongii, Neotricula aperta. So this Neotricula aperta lives in rocks along rotting wood. So you can see here they are attached. They're small snails attached to the rocks, to rotting wood, and they prefer mild to moderate streams of water, shallow waters, which Mekong River provides. So this is the life cycle of Neotricula aperta, and take a look at the low water level from February to mid-May, where there's where the oviposition, the hatching of eggs, and the peak population happens. So Neotricula aperta prefer shallow waters, so they expand its population in low water period. And in high water period, they face hostile environment, but some of them survive to copulate and repopulate. So how can climate change affect the population of these snails? So according to Mekong River Commission, there is projected decrease in water discharge during the high water period. So we can expect that the high water period will be less hostile to these snail populations. And therefore, there will be more snails to repopulate, and there will be more intermediate hosts for S. mekongii. And in general, these are the drivers of schistosomiasis incidence related to climate change. So we can see here the impact of dams, irrigation systems on the predators of these snails, which through dams, it can be rechanneled to other parts, therefore decreasing the chance of these predators of snails to expand its population. So for the clinical pearls of schistosomiasis, we can see here the importance of careful travel and residence history review, and the clinical manifestation of S. mekongii infection. There is no Katayama fever in S. mekongii infection, except in tourists, because tourists are not that exposed to S. mekongii. And also, hepatic schistosomiasis must be considered in patients without stigmata of cirrhosis, but who presents with splenomegaly, portal hypertension, and bleeding. So let's take note that typically hepatic schistosomiasis does not present with the stigmata of cirrhosis unless the hepatic schistosomiasis is in decompensated phase already. So patients with schistosomiasis do not develop cirrhosis unless co-infected with another organism or virus. So we can see here in Cambodian traditional practice, Chaan Sorsai, the heating of the body, this can provide clues for chronic abdominal pain. And if we see this in our patient presenting with chronic abdominal pain and she or he lives near the Mekong River, we can suspect schistosomiasis. So for the classic control for schistosomiasis, there's this preventive chemotherapy with praziquantel. So mathematically, researchers advise at least 85% coverage. The classic provision of water, sanitation, and hygiene, and the prevention of contamination of the Mekong River or any water source with feces from the definitive hosts, which are humans, dogs, and pigs. And as I have stated earlier, the low water period is where the peak population of the intermediate host is. So the inhabitants there will be advised less contact with water during the low water period, which is from February to mid-May. And the impact of dams along Mekong River should be also monitored. Now let's go to urban infectious diseases. First, leptospirosis. So as we know, a heavy rainfall and flooding are the most cited determinants of the seasonality of leptospirosis. According to projections, since temperature decreases the duration of flooding, there is an expected decline in disease incidence in Southeast Asia. However, there will be a linear increase in very urbanized areas because of the effects of urbanization, of contaminated soil, deforestation, and agricultural intensification. So this further increases the human contact with floodwaters. And for leptospirosis, we must always remember the post-exposure prophylaxis for leptospirosis with doxycycline. Early diagnosis and treatment will also help the patient not experience severe leptospirosis. And we must consider tests for leptospirosis in patients presenting with dengue-like illness and jaundice, because jaundice rarely presents in patients with dengue. And these are the typical syndromes where we must be alerted and we must think of this is leptospirosis. So as you can see here, a conjunctival suffusion. So this is more prominent also in the palpebral side. So however, the absence of suffusion does not rule out leptospirosis. So we must still use other clinical clues and diagnostic tests to diagnose leptospirosis. And for public health pearls, we must be mindful that peaks of leptospirosis occurrence may differ among regions of provinces. So hospitals must be alerted when to intensify resource allocation in this specific province for this specific time. And leptospires may persist in water and soil. So this has a big impact in the urban areas specifically. So we can see here for the leptospirosis in Thailand, usually the peak is in October, but the peaks of incidence differ among the regions in Thailand. So the practice of the type of rice cultivation affects the outbreaks of leptospirosis. So we can see here in the northeast versus the central parts of Thailand, we can see that there are differing leptospirosis risk assessment, but they have the same risk factor. So why is this the case? Because in central Thailand, the farming is more mechanized than the northeastern parts. So therefore, farmers are more exposed to the soil and water through traditional farming in the northeast parts of Thailand. And in the south parts of Thailand, the flooding plays more a role in shaping the outbreaks of leptospirosis. So you can see here the differing peaks of incidence rate, which is indicated in red. So for northeastern, it is in October. For southeastern, it is in December. And for southwestern, it is in June or July. So hospitals must be alerted accordingly to each month of peak incidence of leptospirosis. So this is the transmission of leptospirosis through rodent urine and leptospires in soil and water. So how can we prevent leptospirosis? So wearing of protective clothing, so anything that will hinder the contact of contaminated water with wounds or with the skin, basically, because there's also the low risk exposure to leptospirosis. For dengue, we can also see that heavy rainfall and flooding affects the transmission. Temperature, however, has a great impact on dengue transmission, especially in the mosquito populations. So mosquito densities are expected to increase from 25% with climate mitigation measures. But if there will be no climate mitigation measures, they are expected to increase to 46%. So we can see how our action shapes our health. Transmission of dengue, take a look at the extrinsic incubation period, because the extrinsic incubation period dictates the multiplication of the mosquitoes. So EIP is the period from when a mosquito ingests infectious blood meal to when it becomes infectious. So when the lifespan of the mosquito is more than its EIP, then there will be transmission of dengue. So we can see here that the optimal temperature for dengue transmission is 25 to 30 degrees Celsius. So through climate change, we can infer where dengue transmissions can happen. It can also happen in temperate parts of temperate countries, and it can be intensified in tropical countries. So for clinical pearls, let's remember dengue warning signs, because this will guide us when to refer to the hospital. And we must also be mindful of dengue diagnostics. So the advised diagnostics for the first week during the fever onset is NS1, which remains positive until 12 days after fever onset, but there is less sensitivity. So IgM will be more useful in that period after greater than 1 week after the fever onset. So these are the dengue warning signs that will guide us when to refer patients or when to go to the nearest medical center. So a drop in body temperature plus intense abdominal pain, bleeding from gums or nose, restlessness, persistent vomiting, fatigue, and drowsiness. So again, just like leptospirosis, peaks of dengue occurrence may differ among regions of provinces, as seen here. So the peak of dengue in most of Thailand happens in June to August, which coincides with a rainy season. But in the highly urbanized Bangkok and other provinces, it will be on October or November because of the introduction of Aedes albopictus, aside from the main vector, Aedes aegypti. So these are dengue prevention tips from our Department of Health here in the Philippines. So search and destroy mosquito breeding sites, which are the puddles of water, stagnant water in containers, so self-protection measures, seek early consultation, support fogging only for impending outbreaks, and sustain hydration for patients without dengue warning signs. So this is a short guide on how we take environmental history. We must never neglect environmental factors, climatic factors, since this shapes our health greatly. And to end, I want to end with this quote: all your life, you live so close to the truth, it becomes a permanent blur in the corner of your eye. And when something nudges it into outline, it is like being ambushed by a grotesque. So let's not be ambushed by the grotesque of climate change. We have been neglecting it for so long in our medical history taking, in our treatment. So let's learn from the lessons, and let's be mindful of the effects of climate change on infectious diseases and other diseases. These are my references. Thank you for listening.
Thank you very much, Dr. Karandang, and for your summary, for that very extensive discussion, and also for that powerful reminder towards the end. So there you have it. That's the end of our third session. We went over time again, and it has been very rich and fruitful. The discussions in the chat box are full of energy, and hopefully you will be joining us again on Thursday, because we will be discussing the impact of climate change on non-communicable diseases. Kind reminder, don't worry, you will be receiving the slide decks. We're just sorting them out. You will be receiving them via email. They will also be in the website. So patience is key. I just want to kindly remind our colleagues. And also the recordings will be shared with you. The sessions, the first and second sessions are actually already posted on the YouTube channel of the Global Consortium on Climate and Health Education. So thank you again. See you on Thursday. Stay safe and take care. Bye.